Neurology Quiz number 30. What are the newly approved medications for neuromyelitis optica spectrum disorder or NMOSD? NMOSD is associated with pathogenic antibodies to the aquaporin 4 receptor. Aquaporins are a family of water channels regulating the transport of water in all organs, including the kidney, GI tract, secretory glands, nervous system, and muscle. Aquaporin 4 is the most abundant aquaporin in the CNS and is located in the astrocyte foot process. In the pathogenesis of NMOSD, T cells are activated on recognizing aquaporin 4 and in turn activate B cells, forming plasmablasts and plasma cells that secrete aquaporin 4 IgG antibodies. Interleukin 6 or IL-6 is involved in the maturation of T and B cells. Aquaporin 4 antibodies in the blood enter the central nervous system and interact with the aquaporin 4 protein on astrocyte end feet. This interaction leads to complement activation and a downstream effect that causes myelin damage. This is a figure showing the relationship of the astrocyte end feet to the blood vessel and the location of the aquaporin 4 channel. This is a figure illustrating the pathogenesis of NMOSD. Aquaporin 4 is recognized by T cells, which in turn activates B cells, leading to formation of plasmablasts and plasma cells, a process aided by interleukin 6. The plasma cells produce antibodies to aquaporin 4. These antibodies enter the bloodstream and are carried to the central nervous system, where they interact with the aquaporin 4 receptor, leading to complement activation. Complement activation causes downstream effects, which leads to myelin damage. Acute attacks of NMOSD are treated with high-dose IV solomedrol 1 gram a day for 5 days, followed by an oral taper for 2 to 8 weeks. Corticosteroids reduce edema and inflammation in the affected areas. Patients not responding to corticosteroids are treated with plasma exchange, the mechanism for which includes reducing aquaporin 4 antibodies, complement, and cytokines. Intravenous immunoglobulin may also be used if plasma exchange is not available or contraindicated. It reduces humoral factors and modulates cellular processes and cytokines. Maintenance/preventive immunotherapy is essential given the relapsing nature of the disease. Such medications include azathioprine, mycophenolate, and rituximab. Newer agents which are FDA approved for NMOSD and work at different sites at the pathogenic pathway are as follows. Inebilizumab or Uplinza. This is a monoclonal antibody that targets CD19 on B cells, including plasmablasts and plasma cells, resulting in B cell depletion and reduced antibody production. It is indicated for aquaporin 4 antibody positive NMOSD and received FDA approval in 2020. Its approval was supported by the phase 3 Momentum trial, which showed a significant reduction in relapse rates and NMOSD-related hospitalizations when compared to placebo. The initial dose is 300 milligrams IV infusion, followed 2 weeks later by a second dose of 300 milligrams. Subsequent doses starting 6 months from the first infusion are 300 milligrams IV infusion every 6 months. Screening for hepatitis B virus and active tuberculosis is recommended prior to initiating treatment. It is contraindicated in patients with active hepatitis B virus infection, and active tuberculosis will require treatment before starting the medication. Pre-treatment testing for quantitative serum immunoglobulins is also performed, and it should be administered with caution in patients with low serum immunoglobulin. It is recommended to administer live or live attenuated vaccines at least 4 weeks prior to the initiation of treatment. Side effects include infusion reactions with headache, nausea, fever, skin rash, and shortness of breath. Pre-medication with steroids, antihistamines, and antipyretics is recommended. It is associated with increased risk of infections, and most common infections reported include UTI, nasopharyngitis, and flu-like illnesses. No confirmed cases of PML have been reported. Decrease in IgG and IgM may occur with prolonged administration and can also cause lymphopenia and neutropenia. Satralizumab or Enspryng. This is an interleukin-6 receptor antagonist approved for treatment of aquaporin 4 antibody-positive NMOSD. It received approval in 2020. It was studied in 2 randomized controlled phase 3 trials, the Sakura Star monotherapy study and the Sakura Sky study, which evaluated the drug when used concurrently with baseline immunosuppressives. Both studies demonstrated sustained efficacy and favorable safety profile in adults with aquaporin 4 antibody-positive NMOSD. It is administered subcutaneously. The recommended dose for the first 3 administration is 120 milligrams at weeks 0, 2, and 4. This is followed by maintenance dose of 120 milligrams every 4 weeks. It can be self-administered by the patient. Prior to treatment, patients should be screened for hepatitis B virus and TB. It is contraindicated in patients with active hepatitis B virus infection, while patients with active TB require treatment prior to initiating therapy. Patients should have screening LFTs prior to starting treatment, and caution should be exercised in starting treatment in patients with elevated ALT/AST. Immunization with live or live attenuated vaccines is recommended 4 weeks prior to starting treatment and 2 weeks prior to starting treatment for non-live vaccines. Common side effects include nasopharyngitis, upper respiratory tract infections, headache, rash, arthralgia, fatigue, and nausea. Injection site reactions include pruritus and skin mass. It can be associated with elevated ALT and AST, and liver function tests should be monitored every 4 weeks for the first 3 months and then every 3 months for 1 year. If levels are elevated more than 5 times the upper limit, it may need to be discontinued. The drug can also cause neutropenia and hypercholesterolemia. And lastly, eculizumab or Soliris. This is a humanized monoclonal antibody that binds to the terminal complement protein C5 and inhibits its cleavage into C5a and C5b. In 2019, it was approved as the first DMT for treatment of aquaporin 4 antibody-positive NMOSD. This approval was based on the results of the phase 3 PREVENT trial, in which it significantly reduced the risk of relapse relative to placebo. The recommended dose is 900 milligrams IV weekly for the first 4 weeks, followed by 1200 milligrams IV for the 5th dose 1 week later, then 1200 milligrams IV every 2 weeks thereafter. It is given as an IV infusion over 35 minutes. It can be associated with life-threatening and fatal meningococcal infections. Patients should be immunized with a meningococcal vaccine at least 2 weeks prior to the first dose. Eculizumab is available only through a restricted program under a risk evaluation and mitigation strategy. Common adverse effects include nasopharyngitis, upper respiratory tract infection, headache, and nausea. It is also approved for the treatment of drug-resistant myasthenia gravis, paroxysmal nocturnal hemoglobinuria, and hemolytic uremic syndrome.